we are discussing about how to approach a patient of respiratory disease. Towards this approach, I have already discussed you how to take history. Now, after the good history, a good clinician should be able to know about the diagnosis. And if you are not able to know one diagnosis, well, you have to know about the differential diagnosis. But the indicator of good history, I must have told on previous occasion, that if you have taken history adequately, completely, then it should address finally about what is the provisional diagnosis. If you cannot think of one, you may think of 2, 3 diagnoses that you call it as differential diagnosis. Then after a good history, the next part comes while approaching to a patient of respiratory disease is the examination. And as I always say that examination consists of 3 issues. The first thing is the general examination. The second thing is the systemic examination, but in systemic examination, from the history you are aware that which system is involved. So, that system should be examined first. And what do you mean by this? Examine first means you have to spend more time on the examination of the system which appears to be involved from the history. And then the third part of the examination, I always say, is the rest of the other system. So, that is how we go for examination. Now, let us talk about the general examination. I will not go much of the details, but what I wanted you to know that the general examination, although in your case sheets there are many points which are written, but as a clinician, what I usually teach my students that you should know according to the case, according to the system involved, what are the points in general examination which are very important. Even if you have a less time, so you should not miss those points. That's the idea. Since here today our interest is the respiratory system, so naturally question is that what are the points in general examination which are very important, which you should never miss. And another way of knowing this, what are the important issues, many times when you present your general examination, you say many negatives. So, probably those negatives are important issues in the general examination. Like if you do a general examination, what I always say, you have to do everything what is written in your case sheet. But then you have to know that what is the important issues and what is their importance. Like in general examination, any patient, if I examine first as a general examination, what I see, I would like to know his orientation. Is he oriented to time, place and person? Question is, what could be the importance in respiratory system? You know, when patient is in hypoxia or in hypercapnia, these may be deranged. Patient, many times we have seen, you have entered into ward and patient started behaving differently, abusing you, sometimes fighting with you. So, as a clinician, you have to understand that this is something is happening with his consciousness, with his orientation, and there as a clinician, you should suspect that whether my patient is in respiratory failure. Otherwise, for which you need ABG and other things. But even by the general examination, of just overall impression of the patient, you can know that yes, my patient may be in the respiratory failure. So, we start from orientation. Means he must be oriented to time, person and space. That's the usual question we ask. Then after the orientation, what next is important in general examination? Next is important, as you say, whenever you present any respiratory case, you say, sir, there is no cyanosis, there is no clubbing. It means it is very important. If there is a cyanosis, if there is a clubbing, your differential diagnosis will be pruned down. Suppose somebody has clubbing, and if you know the respiratory causes of clubbing, so you can prune down your differential diagnosis. If I say that what are the respiratory causes of clubbing? Respiratory causes of clubbing mostly it involves the suppurative lung disease like bronchiectasis, which is very common, lung abscess, empyema. These are the three suppurative lung diseases. Suppose you got a clubbing in your general examination, and if you are suspecting out of any of these three conditions, so your differential diagnosis would become very obvious. Cyanosis, of course, it deals with the management. As I said, that history and physical examination is not only for diagnosis, sometimes it can help in your management also. If somebody is cyanosed, so question is this: if somebody is cyanosed and you have not examined him and you say, sir, there is no cyanosis, it means you are committing a crime. Probably you are committing a crime. So why these points are important? That why they say no, 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 it means you have to examine those points, even if you have a less time. So cyanosis, clubbing. Now question, what else in general examination may be important? In general examination, next may be important about the swelling over the feet. How the swelling over feet is important for respiratory physician is that you know that many of our respiratory patients, they may slip into the carpal tunnel and they may develop, it means they may develop a congestive heart failure, and most of the signs of congestive heart failure are extracardiac. So you have to go into the periphery and find it out, and one of them is swelling over the feet. If suppose somebody comes to you with the swelling over the feet, we know that there are hundreds of causes of swelling over feet, like anemia, hyperproteinemia, liver disease, kidney disease. But one of the causes, as a respiratory clinician, we should always keep in mind, is it a congestive heart failure because of the lung diseases? Because why it is important to detect? It is important to detect because the management will differ. A patient of a COPD who has come without congestive heart failure, a patient of a COPD who has come with the congestive heart failure, ultimately the management would differ. So that is why these points, what I am telling to you, are very important to a clinician, either to make diagnosis or to make the management issues. Then another point which is very important, which we have seen many of the students, they default, is the lymph nodes. Lymph node is another way, what you say in your general examination, most of the students are in habit that there is no significant lymphadenopathy. But I always say, when we use these words, there is no significant lymphadenopathy, what you are supposed to examine at least cervical, axillary and inguinal. So these three groups of superficial groups of lymph node, they must be examined thoroughly before you say, sir, there is no significant lymphadenopathy. I would narrate you a very small patient, a very small case, which might compel you to think that this is very important. I remember in 90s I was sitting in my OPD, some of the employee of KGMC came to me with an X-ray, chest, and he asked me that some of the professor of medicine asked my opinion about the X-rays. So I said, I saw the X-ray and I found that X-ray is normal. So I said to him, X-ray is normal, but then I ask another question to him, why you are showing me the X-ray? What is the problem with your wife? So he said, sir, my wife is suffering from fever for last 6 weeks. So I said, well, X-ray is normal, because it's a rule. If somebody has pyrexia under observation, X-ray becomes mandatory. In that way, the X-ray was done. But X-ray was normal limits. So I said, X-ray is normal. Whether respiratory system is normal or not, I cannot tell without examining the patient. That you can understand what is the importance of examination. Next day, he came with his wife, and when I examined him thoroughly, means when I said examination means first I will examine the general examination. I just put my hands over the supraclavicular or the cervical area, and I could find the only finding in that lady was a single isolated lymph node in the right supraclavicular area. A young lady who had a lymph node, isolated lymph node in supraclavicular area, which is formed, which is not hard, likelihood is the diagnosis is tuberculosis. So I got FNAC done, and it proven to be tubercular, and I know his fever has subsided. Now question arises, then I asked that gentleman, how many doctors have seen your wife before me? He said, sir, you are the 6th one. So what has happened? What those 5 physicians did? They did, as you say in your MBBS classes, that sir, there is no significant lymphadenopathy. So they are just repeating those sentences without examining the lymph node. And in that lady, I think the sole manifestation of a disease was only finding in general examination. No other. I have just said X-ray was normal. So what I am trying to say that these points are very important. That lymph node, many times you don't examine those lymph nodes, and you are in habit of saying, sir, there is no significant. I have seen in my own clinical practice, this is a very important for a respiratory. I have diagnosed many patients of lung cancer, tuberculosis, like thing only by sticking to this point that I have to examine the lymph node in general examination. I have already talked to you, when I say lymph node means it's not only cervical group, it's all the 3 groups must be. So lymph node is another point in general examination which is very important. Then in general examination, of course, for this system, you examine the nose, you examine the throat, you examine the oral cavity for any problem in these situations. Like I always says, you must examine the nose as a clinician. I was telling, I have seen many patients in my own life that they are just suffering from deviated nasal septum, has a deviated nasal septum, which you can at least have some idea. Finally, the answer will come by X-ray PNS and ENT exam, good ENT examination. But as a clinician, you can have some idea that whether his nasal septum is straight or deviated, and that deviated nasal septum may be linked with the respiratory symptomatology. So you will be ultimately able to. I still remember many cases where they presented to us like asthma, like COPD, and they had a very severe DNS, and when those DNS were surgically corrected, and most of their symptoms have disappeared. In fact, they don't have asthma, in fact they don't have COPD, but they have, because of this, they have a symptoms like asthma and COPD. So that is, general examination means this, that you have to look overall what are the other issues which can help me in making the diagnosis. So these are the major issues in general examination which you usually. So I said orientation, I said what else? Orientation के बाद cyanosis, clubbing, lymph node, swelling or feet, oral cavity, nose, throat. There are many issues. We have seen many patients of hemoptysis where there was ulcer into the oral cavity, and that was bleeding, and that's how the patient presented with us. You must have heard the pseudohemoptysis, means that when the source of blood is above the larynx. It may be from gingiva, it may be from teeth, any gum may bleed, any teeth may bleed, and that you can find out from the good general examination. So what I am trying to say, that general examination has its own role to play. If somebody has come to in your OPD and his extra respiratory muscles are working, so you can find it out from then and there, yes, that he has some problem in the respiratory system. So what I am trying to say, the first part of the examination, which is general examination, is very important. People feel that it may not be important, just say there is no cyanosis, there is no clubbing, there is no lymphadenopathy. So that will not work. And I always say, suppose you say there is no cyanosis, suppose you say there is no clubbing, that is why I said these negative points are very important, and suppose there is a clubbing and there is a cyanosis, probably you are not doing a justice to your patients. That is about the general examination in very brief. Then when general examination is over, I always say that suppose somebody in the history you have got cough with large amount of expectoration recurrently occurring from so many years, and if patient entered in your room, you saw his or her nails and you find there is a clubbing, your diagnosis is very clear. Probably you are going to see a case of a bronchiectasis. With the background of that history, with background of that finding, you may think of a diagnosis very clearly. So that is about the general examination. Now next, after general examination, I said you have to examine the respiratory, as first system is the respiratory, because we are talking about the respiratory system. Now respiratory system, as you examine any other system, is the same way is examined, means under 4 headings you examine: inspection, palpation, percussion and auscultation. Those are 4 headings, same as you do in every system. And if I ask you a question, out of these 4, which one is the most important? My answer would be inspection. That is why this is kept like this. Otherwise, somebody would have kept like auscultation, and what you do? You mostly you do the auscultation. So first thing is first always. So while you inspect, so inspection in respiratory system examination is very important. Now in inspection, I used to say that you have to look for 5 issues, 5 things. Always remember. But before looking for those physical signs, one more thing I would like to tell you, that while inspection there would be adequate exposure, there should be adequate light. An inspection of respiratory system, what I have seen, many people they do from front, maximum they have done from the back, and they miss about the lateral profile of the chest. So what I am trying to say, while you inspect, usually in the books there are prescribed as you see from the front, you see from the back, you see from the lateral side, and you see from the above down and below upwards. So get an exact idea of what are the findings in the inspection. Because inspection, and I always make a rule that while you do inspection, the first point is the movement of chest. See that if anybody is sitting adjacent to me, and if I have adequately exposed him, the first thing I would like to see is the movement of the chest. Then the next point, immediately I would like to see shape of the chest. Then I would like to have a comment about the trachea, if it is possible. Trachea means you see by the trail sign. During the inspection, you see a trail sign, and then you say that trachea might be shifted on that particular side. Then the fourth thing is apex beat, movement of the chest, shape of the chest, trachea, apex beat, and the fifth thing what is seen in respiratory system examination, which many of us miss, is the spines. Because you should remember that if there is a spinal deformity, there could be deformed shape of chest, even there is no respiratory disease. That's why spines are always thoroughly looked. So during inspection, these 5 things are seen. And another thing you should always remember while doing the examination, that for every examination, any point you are examining, you must think what is the appropriate position of the patient in which you will examine that particular point. Suppose you want to see a trail sign, and somebody is sitting like tilting his neck on the one side. You cannot comment. So for a trail sign, what posture is essentially required? Somebody either sitting erect or standing erect, not tilted on one side and slightly neck flexed. Then you see which of the sternal head of the sternomastoid muscle is prominent. That tells about the trail sign. And trail sign, most of the time it may be taken as the trachea is shifted, but it's not necessary. There could be many issues otherwise in fascias and other things in muscles which can produce a false positive trail sign. So that you have to remember. So like say next is apex beat. Now question is, which of the position apex beat should be seen or felt ultimately? Apex beat is not a finding of basically inspection, but many times these beats, finally you just do the palpation, and there you palpate the apex beat. So we'll talk when you talk about the palpation. So the during inspection you have to see the movement. What is the importance of movement of chest? Movement of chest tells you which side is diseased one, which is a very $100 question. Always in our mind that where is the disease? Right side, left side, upper portion, lower portion, and that decision is taken. That's why I said when do inspection, the first thing ideally should be done is the movement, because with that you will see everything further. Suppose somebody's right side is moving less. Now you can also argue no, left side is moving more, because it is always a comparative finding. But in chest you remember nothing moves more. It will be either normal or it will be less. So the side which is moving less is the disease side. That rule you have to always keep in mind. And so movement you have to compare in each areas, and you find out that since we are doing inspection, we have still not touched it, but since during the inspection you can very clearly come out with the which side is moving less or which area is moving less, and that is possibly a disease side. Then after that you say about the shape of the chest. That shape of the chest, there are 2 variations. One is short, stout and thick. It is also known as thick chest, which many of us have. And another variation, normal variation I am talking, is the thin chest, which is long, which is thin. So this variation you have always keep in mind, whether you are seeing a patient which have of thick chest, which have a thin chest. So that's the, and then shape of the chest, you know that it is elliptical in shape. Elliptical in shape means the transverse diameter is more as compared to AP diameter. There is a ratio of 5:7. So when it becomes, when anteroposterior diameter increases, then you call it as a barrel shaped chest, and that indicates the overinflation in the chest. So then you do about the shape of the chest. Shape of the chest, while you comment, there could be bulging, there could be flattening, anything can happen in the shape of chest. As I said, in the movement of chest, it moves in one direction, but the shape of the chest can move in both the direction. There could be bulging, there could be retraction. So in that way, you have to just inspect all the areas and compare it from the opposite sides. That's about the shape of the chest. Then you have to see the trachea by trail sign. Then you have to see any pulsations visible in the over the pericardium, that becomes apex beat. And then finally you just look over the spine and see if there is obvious any deformity. It could be scoliosis, it could be kyphosis, it could be kyphoscoliosis. Why this is important? I have already talked to you, because sometimes there is only scoliosis and there is only kyphosis, and it can generate a lot of findings in the chest, and otherwise the chest respiratory system may be within normal limits. So that's why always we include this spine into the inspection. So after inspection, you go for palpation. And palpation, I always say that all the points of inspection, it means those 5, has to be confirmed, and then you have to add 2 more things. And those 2 things are, first you have to add about what is the expansion of the chest. Now movements and expansion, they are different terms, they are not one. So expansion of the chest, and the next thing what you have to add is the vocal frematus. And equivalence of vocal frematus, while we talk about the auscultation, will be the vocal resonance. They are the same thing. Just to make fool of you, they have been kept at 2 places. So many times people say some different, they say vocal frematus is different, vocal resonance, which is not possible. Both are the same thing, but it is how you demonstrate those physical signs in palpation and in auscultation, that is a difference. So during palpation, what you have to confirm all those 5 issues, means movement of the chest. I will not demonstrate here with patient, sometimes next time when we will say we can demonstrate with the patient, but you have to see the movements, whatever you have seen, you have to confirm it by palpation. And there is method of doing it. So movements you have to confirm, trachea you have to confirm, and for trachea again same thing, you have to think that what is the real what is the actual position in which you palpate the trachea. For the palpation of trachea, what you have to do, you put your finger over the supraesternal notch, move the finger on one side, then on the other side. Where you feel more resistance, it means trachea has shifted onto that side. That is how you confirm the trachea. Whatever impression you have got during the inspection by trail sign, that you confirm during the palpation. You have to confirm if there is any visible pulsation, you have to confirm about the apex beat. Now apex beat is, as I said earlier also, it's a finding of palpation. Neither it is a finding of auscultation nor the inspection, because as you see, what is the definition of apex beat? Apex beat is the lowermost, outermost part of the cardiac impulse which is best felt. So as per definition, it is a part of palpation. So I was telling you that what are the position in which you palpate for apex beat. when you palpate for apex beat, because this is the final thing, after, if it is not palpable, you may declare that apex beat is not palpable. Many times apex beat is not palpable. So what you do before you declare that apex beat is not palpable? The first position is, first position ideally should be the while the patient is lying down. First position for palpating apex beat is lying down position, lying supine. And how you palpate the apex beat? You put your whole palm over the pericardium and try to feel that some pulsation, and then you localize with the help of one finger. You localize it, because you have to localize it. If it is diffuse, as per definition I talked to you, it is the outermost and lowermost part of the cardiac impulse which is best felt. So lying down is the first posture. Then if it is not palpable in lying down, ask the patient to sit. It may apex beat may little change the position and you may able to palpate it. Then still if you are not able to palpate, you may ask the patient to lie on left lateral side. And still it is not palpable, then you may ask your patient to do some exercise, mild exercise, provided you have to assess, provided patient can tolerate that much of exercise, then you can ask him to do exercise and then you palpate again. If it is not palpable after these attempts, then you have got every right to declare that apex beat is not palpable. And as I said, one of the position is left lateral side. But in some of the books, it has written that this is not a very preferred position. Why it is not a preferred position? Because when you ask the patient to lie onto the left lateral side position, the position of apex beat may change. It may be good for cardiology, where you wanted to know, the more you wanted to know about the character of the apex beat. But for respiratory medicine, for the respiratory physicians, we are more interested in knowing the position. So although while lying on the left lateral side, you may be able to palpate the apex beat, but then question comes, is it a real, because here we are more interested in position. That's why some of the book have a little objection that one should not do on the left lateral side. But to my understanding, if the apex beat is not palpable, you can do it, but that thing you have to keep in mind. Whatever position you may be getting, it may be little fallacious. So after confirming the movement of the chest, shape of the chest, trachea, apex beat, and finally you confirm the spines. And in confirming the spines, what you have to do, you have to mark each of the spinous process and you have to see what is the shape of the spine. Kyphosis will be visible from very distance, but scoliosis sometimes is not visible. So you have to mark those lines, those points, and make a line and see that how the spine is behaving. So that and then as I said, you have to add two more things, that is the expansion of the chest. Normally expansion of the chest is about 5 to 7 centimeters. But in case where lung is totally overinflated, say in COPD, the expansion, because the lung is fixed in a full inspiration, so the expansion becomes very less. And many books have talked that if expansion is less than 2 centimeter, then it may indicate that there is a overinflated chest. So an expansion is, while measuring the expansion, you have to have inch tape, and it is done in the males, it is measured at the level of nipples, and in the females it is measured below the mammary area, some memory area. So that is how you just make it. You ask the patient to take deep breath, and then how much it is expanding, you note it down. So that's the, and the second point you add in palpation is the vocal frequencies. Vocal frequencies means you do with your hands, either the flat of the hands or with the ulnar side of the hand, and you just keep it over the chest on both sides, and you ask the patient to say 1, 1, 1, 1 or 1, 2, 3, anything you prefer, and the vocal frequencies and so the vocal resonance will depend upon how loud a person is speaking, and they can the conduction of air, how the air is conducting in both the things. So usually we say that don't speak very loudly, you say 1, 2, 3, 1, 2, 3, 1, 2, 3, and then you compare on both the sides to know about the vocal frequencies. We'll talk in auscultation about the vocal resonance, but that both the things implies the similar meaning. Now after palpation, what you have to do is the percussion. Now I always say that percussion is an art. And what is art? It requires practice, without saying. So not that you will learn percussion very quickly. So I always say whenever you get an opportunity to examine a patient, you must percuss. This is for one reason. And the second reason why you percuss, because in percussion there are many rules of percussion. You can read in any books that you use 2 fingers, pleximeter and flexor, and there are many rules have been written, and those rules has to be followed. I'll not go into details, but while doing a percussion, what is the first thing what you have to decide is first you have to percuss all over the chest, and the first thing you percuss is over the clavicle, and over the clavicle the percussion is without pleximeter. It is the direct percussion. You stretch the skin over the clavicle and you percuss and compare with the opposite side. Then you percuss front of the chest, compare it from the other side, back of the chest, compare it from the other side, then axilla and compare it from the other side. That's how percussion goes. And why I was telling that it is an art, because while you percuss, the normal percussion note may differ from individual to individual. That is one. Not that every patient you are percussing you find the same, although there will be normal resonance, but it may differ depending upon whether it is thin chest, more muscles, less muscles. It will be resonant, but the note may differ. And even in the same patient, from area to area, the normal resonant note may differ. Means in the area where there is a less muscle, say infraclavicular area, there is less muscle. There the normal resonant note may be little different as compared to a suprascapular area where a lot of muscles. Less muscle in infrascapular area, less muscle in infraclavicular area, more muscles on supra. So that is why it requires a practice. That normal percussion note, what you have to identify, what you have to keep in your mind, that it may differ from individual to individual. A person who is 30 kg and a person who is 90 kg, there the muscle and everything would be different. So their note also will be different, but believe me, they are all normal percussion notes. So while you have percussed, and the another thing in percussion is that while you percussion on the right side, you find front of the chest, you find there is a liver dullness. And liver dullness is usually from the resonant node you find a dull node, and that is called as liver dullness. It is percuss in the mid-clavicular line, and usually liver dullness is present in 6 intercostal space. Since it is a comparative finding, so what happens when you percuss on the right side and compare it from the left side, so wherever there is a liver dullness, on the left side it will be a tympanic or hyperresonant node because of the TROPS space. That is the normal finding. So those normal things you have to always remember. And TROPS, what is the TROPS space? TROPS space is a just like you percuss on the left side, it starts from above and come to the down, then from resonant node will be followed by hyperresonant node or tympanic node, and that is the area of a TROPS space. TROPS space, believe it, many of the students don't understand, this is not the area of abdomen, this is the area of chest. That is why it is to our interest. And so TROPS space boundaries could be, the upper boundary is the lower border of the lung resonance, and lower boundary is by subcostal margin. That is why I said the TROPS space is the finding of the chest, not the finding of the abdomen. If you go below the subcostal margin, it will be a hyperresonant node because of the fundal gas shadow. And this TROPS space, the medial boundary is by left lobe of liver and lateral boundary is by the spleen. So that is how it is a semilunar area, hardly 1 or 2 finger wide, just above the subcostal margin. You find a hyperresonant or tympanic node that you call as a TROPS space. Now TROPS space, so while comparing right and left, you will find in contrast. Here you find a dull node because of the liver dullness, here you find a hyperresonant or tympanic node because of the TROPS space. That you have to remember, always remember, keep in mind. Many times we ask that in pleural effusion TROPS space is obliterated. This is wrong. In a massive pleural effusion, it may be obliterated, not necessarily. But TROPS space is usually maintained. But TROPS space will be very wide in cases of eventration of diaphragm, in cases of herniation of lung. So that way, sometimes there is a paralysis of the diaphragm by phrenic nerve paralysis. The TROPS space may go up. But TROPS space is more important because it is a comparative finding. You must know that it will be different from right as compared to left side. So while you, as a clinician, I always say that when you percuss, when you have percussed all over the chest, what you have to first define is what is normal resonance. And I have already talked to you, normal resonance, it varies, there is inter and intra-individual variation. It varies from person to person. It may vary from area to area in the same person. That is why you have to learn while you percuss many times you can learn this, that this is a normal node. Now what are the nodes which you encounter in your day-to-day clinical practice? That probably I am going to show you with this diagram, that more than normal is what you call it as hyperresonant. Even more than hyperresonant, what you call it as tympanic. So above the normal resonance there are hyper or tympanic. And hyper or tympanic suggests you that there is more air either in the alveoli or in the pleura. There are two structures, and in disease wise you may convert it into either it is a COPD or emphysema, or else it is a pneumothorax. That is how you find what are the causes of a more than normal resonance. Now, less than normal resonance, the first node what you encounter in day-to-day clinical practice is known as impaired node. Or you can also call it impaired resonance, but you cannot call it impaired dull. Dull is dull. So, what do you mean by this? There would be resonant node, but it will be less resonant. That means it's impaired resonance. And what it suggests to a clinician? Suppose I percuss and I found in one of the apex there is an impaired node. It means some disease is there at the apex of the chest. Just started. Like say some tuberculosis infiltration. Say suppose you find impaired node at one of the bases. It may be a early consolidation, just beginning of pneumonia. It may be just beginning of the pulmonary edema, congestive heart failure. So, those things where there is it may be impaired node. Anything disease which is beginning. So, impaired node. After impaired node, what node you encounter is the dull node. And dull node implies to a clinician either there is a consolidation, complete consolidation, or there is a collapse. These are the two situations where you can find a dull node. And further, there is another node which is described, which is very common, is the stony dull node. When I say stony dull node, and you know, while seeing all these sets of resonance, from this to dull node, it is the sound which matters. Means if you are percussing, I am listening, I can also listen these things. But dull node, as I said, dull cannot be further impaired. Dull is dull. There is no further impairment. So, in stony dull node is the dull node. Note is same. Plus, it is the abnormal feeling of resistance to your percussion finger. So, in stony dull node, there are two components. Resistance. What are those two components? Is that note would be dull, and while your finger pleximeter will feel some resistance. And as dull note suggests consolidation, collapse means complete airlessness. The stony dull note suggests pleural effusion. So, that is how you react with the various type of notes in the percussion. Now, there are one or two more points which you have to remember while doing a physical examination, especially percussion. That you know that if you talk about the pleural effusion, I talked that the fluid is the main cause for the stony dull note. So, always remember a dictum. When there is a fluid, search for air. And when there is air, evidence of air by a hyperresonant note, you must search for fluid. Because many times what we have seen, they are associated together. So, when we are talking of a pleural effusion may be in general pleural space, in a free pleural space, which is very common. Pleural effusion may be encysted, and there are many pockets, many types of encysted effusion. And then The pleural effusion may be also associated with air, what you call it as hydropneumothorax. Now, how to differentiate in percussion these three things? Between a pleural effusion in free pleural space and hydropneumothorax. What you have to do, suppose this is a front line, you have to percuss on the front and you find suppose area of stony dull note starting here. Then you percuss into the axillary line, suppose area of dullness starting like this, and you percuss over the back, so it will come like. So, in a case of free pleural effusion, highest point of dullness goes into the axilla. But suppose there is air and fluid both, means hydropneumothorax, what you will find that here front line, here it is the back line and here is the axillary line. All the three will have in the same level. What you call it, the upper level of stony dullness is horizontal. Always examiner asks you, have you marked it? And that is the indication that there is air and fluid both. If you find, and in case of insisted pleural effusion, there will be no any normal behavior, it will depend upon where pocket is. If it is in anterior parietes, if it is in posterior parietes, if it is in axillary wall, if it is so, depending upon that the stony dull note, it will not behave in any way, right. So, that is how you differentiate between pleural effusion and hydro. And when you find this type of a finding, examiner always asks, have you marked it? Then not that in every case of a pleural effusion you may go for the shifting dullness. But I will talk about shifting dullness, especially you find this scenario, what shifting dullness ideally means is immediate shifting dullness. When I say shifting dullness, everybody means this is immediate shifting dullness, means the time you take to change the posture of the patient. Hardly maybe 30 seconds or 1 minute maximum, 30 seconds. In the same time, this level will change. The area which was dull, it will become a resonant or hyperresonant node. So, that is known as a shifting dullness, and shifting dullness is the most pathognomic physical sign for hydropneumothorax. If anybody asks what is the most pathognomic, because there are few more physical signs which I am going to tell you about the hydropneumothorax, but this is the most. So, upper border of the dull note is straight, immediately you go for shifting dullness, and there will be positive. Shifting dullness positive means area which was dull, it will become resonant. And then if you find this, then the third physical sign, although this is a sign of auscultation, percussion, palpation, whatever you see, is you demonstrate the succussion splash. Succussion splash, what is done usually in succussion splash, you ask the patient, it is done usually in the sitting posture. Before you do it, you must explain to your patient what you are going to do it, otherwise patient may behave very violently. So, you did that, I am going to shake you very vigorously. So, you shake the patient very vigorously and same time you auscultate and you find a splash sound. As you find there is a water into surahi, you must have seen, if you just shake it, if it is half filled, if it is full filled, it will not behave like that. Half filled, you will find a splashing sound. Similar splashing sound is heard, it is not only theory, it is heard. And so whenever you suspect hydropneumothorax, you must look for the straight border, you must look immediately for shifting dullness, and you must go for succussion splash. Another physical sign which is associated with wherever there is a pneumothorax, whether it is plain pneumothorax or hydropneumothorax, is the coin percussion. And in coin percussion, what you do, instead of those two, flexor and fleximeter, you take help of two coins and keep the coin over the chest, percuss with the another coin and listen corresponding over the back. So what you listen in auscultation, the tympanic or some tympanic sound is added to these coin sounds, and then you call it as that coin sound is positive, coin percussion is positive. And this goes with the diagnosis of pneumothorax either alone or with hydropneumothorax. So these four physical signs, they are associated with each other. So as a clinician, not that every patient who has come with you and you will vigorously say, patient will slap you. So you first suspect that yes, I am seeing that there is evidence of air and fluid, and then these special physical signs are demonstrated. The another point, another question which is asked in PG examination, can you get shifting dullness in pleural effusion? This is a $100 question, and its answer is yes. If there is a fluid in the free pleural space, it will shift. But the shifting dullness of pleural effusion and shifting dullness of hydropneumothorax, there is a difference of 15 minutes, 15 to 20 minutes. So that is why usually what we say that shifting dullness, usually we do not do in pleural effusion, because there are enough signs to diagnose pleural effusion. But if somebody asks you whether you can, somebody asks you to differentiate between pleural thickening or pleural effusion, so probably this is a physical sign where you have to go for the shifting dullness. I must have shown you in X-ray is the infrapulmonary effusion. So what you do is a lateral decubitus views, and if you ask any radiologist or radiographer, they say that they have to wait, not just lying down and they will do the X-ray. They have to wait for 15 to 20 minutes, because here if the fluid is alone, it takes time to shift. But yes, ideally speaking, that also shifting dullness would be positive, and that is what is known as delayed shifting dullness. So when we say shifting dullness, it means immediate word is hidden there, it's immediate shifting dullness. So that's about the various type of notes, various special physical sign. And another physical sign which is also demonstrated in percussion is the chronic isthmus. Chronic isthmus. And chronic isthmus is nothing but it is a band of resonance which connect from anterior to posterior chest wall. So what you do, you start percussing from lateral side, from the neck until you get a resonant note, mark that area. Then you start percussing from the medial, from the shoulder till you get a resonant note, and this span between these two resonant points, this span is, so chronic isthmus is always said that normal span of chronic isthmus is again 5 to 6 centimeter. So it can be reduced on one side, it can be absent on one side, and it always speaks about that there is a disease in the extreme apex of the lung, which creates airlessness. So that's about the chronic isthmus. Anything else in percussion we do? Yes, cardiac percussion, you must know that first, to know the cardiac percussion, you should know how the pleura is reflected. Now, if it is clavicle, so pleural reflection starts just above the clavicle on the right side, and it comes into parasternal line, and then at the 6th spate it turns, and 8th, and finally it goes into, so that's how on the right side. How it is reflected on the left side? Left side is different as compared to right. On the left side it starts here, and then at 3rd level it goes like this, and then it comes here at the 6th. So what is superficial and what is deep cardiac dullness? That question many times is asked by examiner which are little older. So if you see this, that's why you see that if you percuss on the right side, immediately you come and find a liver dullness below it. If you percuss, what is deep cardiac dullness? Deep cardiac dullness is very simple. It is a percussion of the heart borders. Means you percuss left heart border and you percuss the right. Right heart border is normally not percussible. Left heart border correspond to the apex beat. Then there is another term which is used is superficial cardiac dullness. What is superficial cardiac dullness? Is the bare area of the heart. Means here you see the reflection, so there is some 2-3 spaces, third, fourth, fifth, third, fourth, different books, different. You find that pleural reflection goes away. So this becomes the bare area of the heart. It means lung is not here, but lung is behind the heart. Lung is behind the heart. So if you percuss, for superficial cardiac dullness, it must be a very light percussion. Because as I said that lung is behind the heart is there, if you percuss it very deeply, you can pick up the lung resonance from behind. So it should be very light percussion, and in the paraesternal line, in third and fourth space, what normally you can find the dullness of the heart. Because front of the heart, there is no lung because of the pleural reflection. So that space is known as superficial cardiac dullness. And superficial cardiac dullness and deep cardiac dullness, they are masked when lungs are overinflated. Means COPD and emphysema, when lung volume will increase, they will cover, lung will come over here. So these dullnesses will be masked. That is why we say superficial and deep cardiac dullness are masked in case of COPD. But appreciation is very difficult. That's why if you just do a very light percussion, then you can pick up the normally superficial. It is normally. And now let me go on to the auscultation. I was taking examination in the Gujarat University, maybe in 2000 around, and there is a one ultrasart case. In ultrasart case, what happens? The examiner is standing and candidate is standing, and examiner will ask something and candidate has to do that within maybe 2-3 minutes. So suppose I ask one of the candidate, do the auscultation of the right infrascapular area. So what he did, he just auscultated. Just heard the breath sound and finished. So I said, your auscultation is not complete. Until unless you, what is visible for distance, until unless you ask the patient to say 1, 2, 3, how the auscultation? And when you auscultate, you have always 3 aims in your mind. First, what is breath sounds like? Second, if there is any accompaniment. And third, what is vocal resonance? I have already said to you, vocal frematus and resonance, they have similar meaning. It's how you demonstrate is different. So, to answer the first question, that is, what is breath sounds? That you have to first understand what are the common breath sounds which a clinician can listen. First, until unless you understand this, you will never be able to appreciate the breath sounds. And normally, you know, we have 2 types of breath sound. Normally, I am saying, because our normal chest, you can listen it. First, normal breathing is known as vesicular breathing, and another breathing is bronchial breathing. Now, when I say what are the differences between vesicular breathing and bronchial breathing, vesicular breathing means when air is passing through the normal lung, you listen to vesicular breathing. Bronchial breathing means when air is passed through the bronchial tree, what you listen is the bronchial breathing. Normally, to be very in general. But what are the differences between vesicular and bronchial breathing? Now, differences are in four issues. The first difference could be in the duration of sound. When I say duration of sound, suppose this is inspiration occurring and this is expiration occurring. So, what you listen in vesicular breathing, you listen whole of the inspiratory phase and then 1/3 of expiratory phase. So, duration of vesicular breathing, what you listen full inspiration and only 1/3 of expiration. So, that is why we always say ratio between expiration and inspiration is 1:3. And what you listen in bronchial breathing as far as duration is concerned, you listen in, this is inspiration, this is expiration. So, what you listen is whole of the inspiratory phase except at the end, and then you listen whole of the expiratory phase. So, here the ratio become 1:1, and of course, there is a gap which I will talk little later. So, this is how the breathing, both the breathing are different as compared as in terms of duration of sound. What is the second difference? Is the character of sound. If you ask me, sir, how you recognize bronchial and vesicular breathing, I will tell it is the character of sound. And for character of sound, what is typically described in vesicular breathing, it is rustling in character. And in bronchial breathing, it is described hollow, oblique, aspirate in character. Now, it is very difficult to define in the words, but I always say, as I say, the character is very important to differentiate between these two types of breathing. You can hear with your own chest. You have not to go to any patient. You listen over your chest, whatever character you are listening. If your chest is normal, it is rustling in character. You put your stethoscope over the trachea, whatever character of sound you are listening here, this is hollow and aspirate. So, what I always tell my students, you need not to go to the patient, you just practice on your own body. You can find out what is rustling and what is hollow, because this is the main point by which we, at least I identify whether it is a vesicular breathing or bronchial breathing. What is the third difference is the intensity of sound. If you concentrate here, when I say intensity, there are two inspiratory sound and expiratory sound. So, in case of vesicular breathing, if I put inspiratory at 2 plus and expiratory as 1 plus, so in vesicular breathing, it is the inspiratory sound which is more intense. So, prominent sound what you listen is inspiratory, because whole of the phase you listen, and then intensity wise it is more prominent. What is the intensity of sound in bronchial breathing? Similar way, inspiration and expiration. Inspiratory is 2 plus, so it is as intense as vesicular breathing, and expiratory I represent as 3 plus. So, here although both the phases are very intense, but it is the expiratory phase which is more intense. That is another difference. So, and fourth difference is whatever explained here about the gap. There is no gap, negative, and there is a gap in bronchial breathing. So, that is how vesicular and bronchial breathing is recognized although these 4 differences are there, but to my understanding, mainly these breathings are recognized by character of the sound, and that I have already explained to you. You need not to go to any patient, you can listen, daily listen on your own chest and on own trachea. You may find what is rustling and what is hollow. Now, when there are certain variation of vesicular breathing and there are certain variation of bronchial breathing. Now, if you see vesicular breathing, concentrate here. If it becomes like this was here, if it becomes like this, whole of the phase is, you are listening, means what this breathing is. So, first variation of bronchial breathing, which is very common, is the vesicular breathing with prolonged expiration. And many books have written it differently, they say harsh vesicular breathing. So, it is very clear what is harsh vesicular breathing. A vesicular breathing with prolonged expiration and it is very important to a clinician. I always say, if you can't recognize a harsh vesicular breathing, it is very difficult to become a good chest physician. Harsh vesicular breathing tells you that there is a airway obstruction. Simple example I can put to you, if somebody is coughing and you listen harsh vesicular breathing, it means his cough is basically because of some airway obstruction. So, it is not the cough suppressant which is going to help this patient. Any amount of cough suppressant will not relieve cough. What will relieve cough? Either the expectorant, some secretion, something are there, or some bronchodilator. So, that's a message very clear to a physician. So, for that you have to first recognize this variation of vesicular breathing. The variation of vesicular breathing could be because of the intensity. You know that very common, you may find more intense vesicular breathing. Can anybody name more intense vesicular breathing? इसका नाम होता है प्यूराइल. प्यूराइल पढ़ा नहीं होगा कभी तुम लोगों ने. Puerile means intensity is increased. It is usually found in children. And then suppose one lung has been removed, over the other lung you may get more intense vesicular breath sounds. This is increased intensity, and very common type of variation of vesicular breathing is the decrease in intensity. Decrease or absent. Decreased vesicular breath sounds are the absent vesicular breath sound. It goes with pneumothorax, it goes with hydropneumothorax, it goes with collapse, sometimes it goes with fibro. Many things can happen to the decrease. So, that is the variation of vesicular breathing, means in duration and in intensity. What are the variations of bronchial breathing? Now, you know, you listen normally the 3 types of bronchial breathing. The one is tubular. Tubular means high pitched bronchial breathing, and it translates to a clinician that there is a consolidation. But catch point is, not all consolidation will produce tubular breathing. Where you are caught in the examination, you just see the X-ray and you try to translate the X-ray into the physical finding. Physical finding is always not possible. So, but once you listen a tubular breathing, it is that there must be consolidation in the X-ray. The next variation is cavernous. Cavernous means low pitched bronchial breathing, and it implies cavity. Reverse is again true, that not all the cavities will produce a cavernous breathing. For cavity to produce a cavernous breathing, there should be a sufficient size, there should be communication with the endobronchial tree. So, there are certain prerequisites why a cavity will produce a cavernous type of breathing. The third variation of bronchial breathing is the amphoric breathing. Although newer books, newer clinical methods, they have removed all these because they don't listen, but we listen in our day-to-day clinical practice. What is amphoric breathing? Amphoric breathing is, once you listen, you will never forget in your life. Amphoric breathing is essentially it is a low-pitched breathing like cavernous, but associated with high-pitched overtones. That's why you listen a very musical type of a breathing. Once you listen, you will never forget in your life. And the causes, so cavernous breathing means cavity, tubular breathing means consolidation, amphoric breathing means two things. One, either there is a pneumothorax or hydropneumothorax with patent bronchopleural fistula, means open type of a pneumothorax or hydropneumothorax. And the second cause for amphoric breathing is a giant cavities communicating with the bronchus. Of course, breathing will only be there when it is communicates with bronchus. So, a size of more than 4 centimeter, even bigger than that, you may get in. So, if you are listening an amphoric breathing, what as a clinician I know that I have to search to either there is a big cavity or there is a pneumo or hydropneumothorax with open type of a hydro or pneumothorax, hydropneumothorax and pneumothorax. So, that's about so there are 3 variations. In India, we still listen these types of breathing if you can, but in exams if you are not able to differentiate, but you can very clearly differentiate between amphoric and other breathings very clearly, but if you are not, tell bronchial breathing. But if you can appreciate, you can subclassify them. That's about the variation of the bronchial breathing. Now, there is yet another type of breathing which is known as, which I used to say it is in between bronchial and vesicular. That's why I am putting here. Is known as bronchovesicular breathing. Newer books have all removed this type of breathing. So, this is not, don't confuse from here. This is a harsh vesicular breathing and this is a bronchovesicular breathing. And when I said that it is in between, so it is between vesicular and bronchial breathing. How you recognize bronchovesicular breathing? Now, as I said, I recognize bronchial breathing by character of the sound. So, to say bronchial breathing, ideally both the phases should have hollow or aspirate in character. When one phase is like bronchial and another phase is like vesicular, when I say bronchial and vesicular means character. So, one phase is, many times you listen in your day-to-day clinical practice that both the phases are not hollow, it's only one phase is hollow. When I was a student, there is a bronchovesicular and there is a vesiculobronchial depending upon which phase is hollow, but this is very clear finding. We even listen today that if only one phase is hollow, so like bronchial and another phase is like rustling or vesicular type, we call it as bronchovesicular breathing. Question arises, what is the significance of bronchovesicular breathing? The first significance what you have to remember that bronchovesicular breathing can be normally heard. And what are the areas where it can be normally heard? Bronchovesicular breathing actually is listening or breathing through a very superficial bronchus, especially in a thin-chested individual. So, what are those areas where you can listen? Sometimes bronchovesicular breathing and sometimes even bronchial breathing. And those are the areas especially in the right infraclavicular area. Why? Because here the right main bronchus are in close approximation with the chest wall. If the person is thin chested, start practicing from tomorrow. If a person is thin chested, you may listen definitely a broncho and sometimes even a bronchial breathing. And what is the another area where normally bronchovesicular breathing is heard is at the root of the lung lies, around T2 and T3 in the back, around the spine of the scapula. You may listen the bronchovesicular breathing because there the trachea is very close contact with the chest wall. So these are the two areas. So bronchovesicular breathing, there are two significance. One, it can be normally heard, that you have to always remember. And the second, if it is not normally heard, then bronchovesicular breathing is taken as a bronchial breathing. Whatever is the causes of bronchial breathing, those causes like consolidation, if somebody consolidation is complete, suppose in the resolving stage, you may not listen bronchial breathing, you may listen a bronchovesicular breathing. Like some collapse, like some fibrosis. Idea is that when superficial bronchus, they have come very close contact with the chest wall, you can imagine such type of a bronchovesicular breathing. That's about, this is what I was interested to tell you, what are the common type of breath sounds which are you can listen. If you know in theory, you can listen it also. Believe me, I listen it daily in my clinical practice. And whosoever sits with me, I usually ask them, just listen and tell me what is the type of breathing. So that was the, when you say auscultation, that was the first aim, is the breathing, type of breathing. What is the accompaniments? Now there are usually three types of accompaniments. What you call is rhonchi is one, creps is another, and pleural rub is third. So these are three common type of accompaniments which you can listen. Rhonchi, as you know, most of you know, it is a continuous type of sound. And rhonchi could be generalized and could be localized. Now generalized rhonchi are common. As you know, rhonchi goes with the airway, partial airway obstruction, not complete airway obstruction. Complete airway obstruction, there will be no entry, there is no question of rhonchi. So it's a partial airway obstruction. And partial airway obstruction, usual diseases are chronic bronchitis, asthma, COPD. These are the diseases where you can get, commonly you listen rhonchi. Harsh vesicular breathing with rhonchi, they are the common finding in airway obstructive lung disease. Now, localized rhonchi is not common, but there is a dictum you should always remember. Localized rhonchi, if it is not persistent, it is not important. Suppose somebody, you are listening rhonchi at one place and you ask the patient to cough and rhonchi disappears. This is not important. Why this is not important? There may be some mucus plugging which has partially obstructed one of the bronchus, and you may listen localized rhonchi, ask the patient to cough and it dislodges and rhonchi disappears. So rhonchi which is localized, which is not persistent, is not important. Localized rhonchi which is localized and which is persistent is important to a clinician. As generalized rhonchi indicates generalized obstruction, so localized rhonchi also indicates the same thing, that is a localized obstruction. Now question is, what are the causes of localized obstruction, partial obstruction? Localized partial obstruction may be when the obstruction is outside the endobronchial tree, means some lymph node pressing partially the bronchus, some tumor may press from the outside the bronchus, can may create a localized bronchitis. The cause of partial obstruction in the wall of the bronchus, like endobronchial tuberculosis, like again malignancy, can be within the from the walls. And the localized obstruction may be from within the lumen. And here example is foreign body aspiration. I would like to tell you one of the story which I diagnosed one of the professor of when I was in KGMC. Again, it is a story of 2000, near about 2000. One of the professor came to my house all of a sudden, because we were closed door neighbors. He came to me and he said to me, Rajendra, I am feeling breathless. All of a sudden. But because I was knowing him, he has been my teacher, he had no asthma, no COPD. But all of a sudden he started feeling breathlessness. Not very severe one, mild breathlessness. So he just immediately came to me. I auscultated his chest. As usual, I did the examination. I did general examination as I told you, because I was seeing whether you see a professor, whether you see a general man, do the same thing. So I did a full examination, and what could only positive find I could find in him is the localized bronchitis. I asked him to cough, probably it might disappear, but it was a persistent localized. So I asked him, sir, whether you have aspirated something in the previous night. So he said, no, I am okay. But the morning I woke up, I am getting breathless. So when I got the X-ray done, but so history was not supportive. So I got the X-ray done. What could I found to my utter surprise in X-ray? There was a tooth-like structure in the X-ray. So it was a crown. So I asked, sir, it is something like tooth. So when he saw his, he's opened his mouth. That's why I said in general examination also these things are very important. So he saw that his gold, he was wearing a golden crown. So that was missing. Holy, where is my crown? And the crown is inside the chest. So what was the cause of the localized bronchitis, which is persistent, is the foreign body aspiration. I know that immediately we got that foreign body removed and he got okay. So what I am trying to say, these findings are not just to write on the case sheet. As a clinician, you have to interpret. So that's the importance of a localized bronchitis. So as I said, generalized bronchitis means very common diseases. Localized bronchitis is not common diseases, but if it is persistent, you must think what could be the cause of a localized bronchitis. You must investigate the patient. Then this is the bronchitis, and what is the another accompaniment which is very common is a Krebs. Now Krebs, there is a lot of change are happening. But as I told you that Krebs are intermittent sound, I will take another class how to differentiate between various type of Krebs in various diseases. I have another package, but here I just to complete the auscultation, I would like to tell you that Krebs are fine and coarse. Although now people have started talking phase wise, which phase Krebs are, but fine and coarse also depend on that. Fine Krebs are those Krebs. I always ask a question, not I, everybody asks this question. What do you mean by fine Krebs? It is not by fine tuning and whatnot, by the, it is fine Krebs means the Krebs which are present in the late inspiration is fine Krebs. Very simple definition. So late inspiratory Krebs are fine Krebs. Rest of the Krebs, if you ask me, can you categorize as a coarse Krebs? But coarse Krebs are usually present in both the phases. Usually. But it may be in one phase. So, fine, what do you mean by fine Krebs? What it suggests to a clinician? Suppose you listen, suppose you percuss and you find impaired note at one of the apex or one of the base, and you find a fine Krebs there, end inspiratory Krebs. diagnosis is very obvious. Either it may be early disease, something like pneumonia, something like tuberculosis, something like early ILDs, you get the late inspiratory creps. Sometimes you get early inspiratory creps. In ILDs, you get all sides of creps. In late inspiratory, early inspiratory, pan inspiratory. So this is, but most of the creps of ILDs are inspiratory creps. Inspiratory creps. In case of, so fine creps means any early disease which is involving at the quite extreme end of the endobronchiality, means alveolus and acinus and other issues. Coarse crepitation, usually, as I said, they could be present in both the phases, and this ideal cause is usually these source of coarse crepitations either in the major bronchus like COPD, bronchitis, all diseases. Bronchiectasis, again coarse crepitation. Dictum is, if the persistent coarse crepitation, whether with the symptom or without symptom, if the coarse creps is persistent in a localized area, it is bronchiectasis. Because why creps? Because there the bronchi is localized, dilated, and their pool of secretions are always there, whether it is infected, whether it is not infected. But pool of secretion will always be there. That is why we always say that coarse crepitation, if it is persistent in a localized area, it is bronchiectasis. Coarse crepitation, if it is generalized, it is COPD. Another causes of coarse crepitation may be, source of it may be in cavities. There is a lot of secretion in the cavity, there also you can get a coarse crepitation. That is how you react with a coarse crepitation. Mind it, I am talking to you approach to a patient. I am not talking to how to do these things, that will take another time, but here we know how to approach. Suppose you listen a bronchi, you listen a localized bronchi, you listen a fine creps, you listen a coarse creps, how it helps you in making the diagnosis or deciding the therapy. The third accompaniment is pleural rub. Pleural rub is again, since it is a rub, cause of pleural rub is usually the pleural diseases. Pleural disease means any inflammation in the pleura. It may be malignant, it could be pyogenic, it could be malignant, pyogenic, tubercular, any inflammation. When pleura rubs against each other, when they are thickened, so you might find a pleural rub. How to differentiate between pleural rub and coarse crepitation? Usually there is a question. Pleural rub, usually it is a rubbing type of sound. Creps are intermittent type of sound. Pleural rub, when you ask the patient to cough, the creps may change. Pleural rub will not change. You press the stethoscope over the chest wall, the pleural rub might increase in intensity. The creps, it will have no change. So these are the few points. And pleural rub, another point I used to say, it is a common sense. Whenever you find a pleural rub, it will always be associated with chest pain. So ask the patient, where is your chest pain? And sometimes you auscultate there, you will find a pleural rub. Another thing what you have to remember, especially when I talk pleural, that pleural, suppose there is a pleural effusion. So in the beginning of pleural effusion, when there is inflammation of the pleura, there will be pain. When pleura separates, when there is fluid, pain will automatically disappear. And when you treat these pleural effusions, when pleura will come again with contact with each other, and if the inflammation persists by that time, then it will again rub and pain will again appear. So those points, probably nitty-gritty, you have to tell your patient that we are treating, you have disease like this, pain may come. Many of the patients come to us, pain sir has reappeared, has come again, sir फायदा नहीं हो रहा, pain फिर होने लगा. So that as a clinician you have to, that's the pleural rub. Finally, to complete the auscultation, what is the third component of the auscultation is the vocal resonance. And as I said earlier also, vocal resonance and vocal fremitus are the same thing. Whatever you have to tell in fremitus, the same thing probably will be there in vocal resonance. And in vocal resonance, what you ask to say 1, 2, 3 slowly, not very loudly. Then you will be able to appreciate 1, 2, 3, 1, 2, 3, 1, 2, 3. And listen with your stethoscope and compare from other side. So, in vocal resonance, it could be a normal vocal resonance, it could be increase in vocal resonance, and it could be decrease or absent vocal. So, it can move in all the directions. Normal vocal resonance, suppose you ask your patient, how you define normal vocal resonance? You ask your patient to say 1, 2, 3 and it gives you impression that it is, these sounds are generated at the level of chest piece. Then you call it as normal vocal resonance. And if it gives you impression that this sound is nearer to your ears, then it means vocal resonance is increased. And if you find no sound or less sound or no sound, so vocal resonance is decreased or absent. Now, increased vocal resonance has 1 or 2 more sets, what people talk about. Increased vocal resonance may be increased to the extent what you call it as whispering pectoral key, highest increase. It means when you test for whispering pectoral key, you ask your patient not to speak 1, 2, 3, not say 1, 2, 3, 1, but to whisper 1, 2, 3. And these whispered words are so clearly audible that somebody is directly speaking, whispering into your ears. This is known as whispering pectoral key. And whispering pectoral key or increase in vocal resonance, these are the sets of increased vocal resonance, will be accompanied with bronchial breathing or bronchovesicular breathing, not with the harsh vesicular breathing. So, if you find increased vocal resonance or whispering pectoral key, always whenever you say there is a bronchial, a rule you have made, wherever there is a bronchial breathing, whether you listen, whether you don't listen, usually you don't listen, but you say, sir, there is a whispering pectoral key. But rule says similar thing, that where there is a bronchial breathing or bronchovesicular breathing, there could be increased in vocal resonance, it may be in the tune of whispering pectoral. And another increased vocal resonance is called as egophony. Egophony is again a shade of increased vocal resonance. What is egophony? Egophony is when you ask the patient to speak 1, 2, 3, the nasal tinge is added to these spoken words. And egophony suggests again either it is present over the consolidation or over nasal tinge. It is what people nasal tinge is added. So nasal tinge is added to this, and this is known, this is found usually over the consolidation, sometimes, not always, or else at the top level of the pleural effusion. So this is known as egophony, and egophony is again a sort of an increase in vocal resonance, and this is usually when the nasal character, nasal tinge is added to the spoken words. This is known as egophony. That finishes the auscultation, and let me summarize and say take home messages that physical, when I say after a history you start doing a physical examination, and physical examination will consist of general examination, system involved first, and the final thing comes to finish this examination is the rest of the other system. Now I would like to say 1 or 2 lines. When I say rest of the other symptom, that is the third component of the physical examination. So that not that in every patient you are going to do all the systems. Suppose somebody is coughing and you started doing a jaw jerk. or knee jerk or plantar extensor. So patient will feel very awkward. Patient probably will feel, are you a doctor? Are you a mad person? So but this is a very essential component. Third component is also very important. No? What you have to decide is that what are the real system where you may have got some findings. Like I always give examples. Suppose you got right-sided pleural effusion. I usually ask, most of the examiners ask, what next system is important? Abdomen is important. Because right-sided effusion, right-sided pneumonia, right-sided anything may come from below the diaphragm. So let us examine what is there in abdomen, if something is there or not. Likewise, you have to be imaginative, and you have to, well, in some of the patients probably you have to go for the jerks, you have to go for the knee reflexes and ankle, because if you are suspecting that type of a disease, so what is meaning by other system? Ideally, all the systems should be examined, but to cut short the time, what is the essential system where you are likely to get some finding? That always in exam people ask, what other system would like to examine? Depending upon your case scenario, you have to think that what other system may be very important. As I always say that somebody had hemoptysis. Probably I must have talked this in history. If you have a hemoptysis, what is the other system? Cardiovascular. I know that 15-20% of the so whether it is history taking, whether it is physical examination, you have to be very imaginative, and within that limited period of time. Here as a resident you have got lot of time, but if you go to your clinical practice where you have got less time, in less time you have to diagnose. Not that you will have an excuse that I have less time, so I will not examine this, so I have not examined this, I was not able to do this, that's why I made the wrong diagnosis. Nobody will going to excuse you. So in that scenario, the third component is taken as what are the necessary other system where you believe there could be findings. So ladies and gentlemen, what I am trying to say that that the physical examination is also a very essential component. You must have experience, you must have by now experienced that many of the physical findings, as a clinician, it helps you in deciding the diagnosis, most of the point in diagnosis, but many of the points out of them, as in history, they can also helpful in deciding the treatment. But idea is that whenever you do the physical examination, always stick to these rules, that three things. First, general examination, that is important point, and then system involved, you spend little more time on that, and then finally the other system. Depending upon your case scenario, you have to choose which other system is important, and that there you have to spend some time. Because if you start doing reverse order, suppose you do the other system first, so you have examined, you took half an hour to examine cardiovascular, musculoskeletal, neurological, so what you will find? You will find nothing. That is why actually these rules have been made after a very thought over process. Not that somebody is these teachings are there for last maybe centuries, many centuries, and these cassettes have been made accordingly, thinking about that what is important, what is less important. So in that particular time you will be able to do. But really to my understanding, physical examination is very essential and very important, and it gives you the very important clues either for diagnosis or for treatment of tuberculosis. Thank you.